Thank you for joining McLaren Northern Michigan today for the second of our four-part orthopedic education series. Today's session is being presented by Dr. Christopher Kennedy, foot and ankle surgeon. Dr. Kennedy will share bunion treatment options to alleviate pain and help regain stability. For the duration of the presentation, all participants have been muted. If you have questions, we encourage you to submit these using the chat feature. These questions are only visible to the moderator. Dr. Kennedy will answer as many as he can at the end of his presentation. For additional questions, to schedule an appointment, and for follow-up information, we encourage you to use the links that will be found in the chat. All registrants will receive a follow-up email after the event that will contain these as well. Thank you for joining us. Now, without further ado, Dr. Kennedy, take it away.
Yeah, thank you very much, you guys. Hopefully we are live here. Appreciate everybody who's on the video today. Thanks for taking the time to learn. I'm assuming it's likely your bunion or your spouses or your family members, but thanks really for taking the time to sit down with us here. I want to talk about what really the bunion is, what some of the mechanical pathologies are that can lead to bunions, and then I really want to emphasize my conservative treatments for bunion therapy. There's two kind of schools of thought: a functional approach to bunions, where we actually adjust the mechanics of your foot, and then there's accommodative, where we pad and we accommodate the deformity, and then finally we'll just touch on surgical options. So this is a bunion, and a lot of people are under the conception that there's actually an accessory bone that is building at the base of your big toe. And in most cases, that really couldn't be further from the truth. It's this really mechanical deviation of the axis of your foot. That metatarsal bone, that long bone that supports the knuckle joint right there of your big toe, that starts to drift inward. We call that medially. Towards the midline of the body. And because of the tethers, you can see in that bottom diagram, because of the flexor tendon and the extensor tendon for the big toe, the tendons that allow you to flex and extend, because of those proximal tethers, it brings the actual digit, the actual toe, laterally. So yes, it looks like there's a base of or a bump at the base of the big toe at the knuckle joint there, but it's really the subluxation of the metatarsal phalangeal joint. People do experience pain at the base right there at that bump. A lot of times it's shear pain because that area will rub against their shoe. They also get interspace pain right between the big toe and the second toe. There's plenty of shear that can occur there. And occasionally they'll get pain within the joint. The flexion when you walk, when you ambulate, that flexion at the metatarsal phalangeal joint, that knuckle joint, with the subluxed joint that is present in a bunion, it's abnormal wear. So you get rapid wear and tear arthritis. A lot of times people are pretty apprehensive about getting evaluated, especially by a surgeon. And hopefully I can put some of those fears at ease. Really, we want to address your specific complaints, those complaints likely of pain or inability to do activity. That's the focus. And a lot of times there's alternative things that can be done instead of surgery to alleviate that pain. And we really just want to make sure that, whatever complaint you have is, what you think it is, you've got good medical data to back up that pathology. When you come and see me in the clinic, I discuss, what's been going on with the bump, with the deformity. What are your limitations? What are your activities? We'll talk especially about any attempts at home therapy, padding, orthotics, physical therapy. I do a pretty thorough physical exam in the office where I check the range of motion, not only your big toe joint and the joints in your forefoot, but also the joints in your rear foot and your ankle, sometimes even your knee and your hip, because those all connect. That's a whole static kinetic chain, and that all drives gait. And finally, when you get seen by me, unless you've had them before, we need to get some x-rays. This is a really powerful tool. And here at the McLaren Northern Michigan Orthopedic Services Office, we have that right in our clinic. We can do it the same day. These x-rays need to be weight bearing. By loading the foot, by putting the force of your body on your foot, we can better understand the mechanical contribution of your foot to the deformity. So that's a really essential part. Not all bunions are created equal, and you can see a variety of them there on your screen right now. It's interesting, sometimes the people with a severe bunion, like you see on the right, they're the ones that are pain-free and are looking to get their bunions fixed for cosmetic reasons, where the people with the mild or moderate, they're the ones who have very significant pain and immobility and are looking for a return to activity with their bunions. That's not always true. It's just important to know that there are varying levels, and really it doesn't steer along with severity. Again, looking at the x-rays here, especially weight bearing, there is a number of contributing factors to a bunion. As you saw on the last slide, not all bunions are the same in terms of severity. Well, not all bunions are the same in terms of their actual mechanical causes and pathologies. So it's important to get a good, thorough workup to really see what kind of bunion you have. I'm emphasizing again that not all bunions are created equal, so that a bunion that was on your sibling or parent, or even on your other foot, that was fixated in one way or corrected with one, may not respond the same way to a treatment course, either surgical or conservative, as the other. Again, you know, the mainstay of therapy is either conservative or surgical treatment. And when we look at conservative, that's non-surgical treatment. When we look at that conservative treatment, there's two routes we can go. There's the functional conservative treatment, and then there's these accommodative surgical treatments. So for me, the functional treatment is based on these three aspects. Functional treatment means we are changing the mechanics of your foot. We're changing how the ground how your foot reacts to the ground. And in some cases, we can actually alleviate really the deforming force on the bunion. We can stop its progression, and we can even maybe retrieve a little bit of that bump pain. The first go-to, and this is for the majority of people, is a good quality shoe. This is again, for the majority, this is a running type shoe, somewhere in the $100 range. The $100 range means that you're incorporating fairly good and new technology from the shoe market. Now, there's intrinsic things you've heard probably of overpronation shoes and neutral shoes and supination shoes. There's all those intrinsic technologies. Those are patient specific. That's something we'd have to discuss in person once I examine your foot. But in general, roughly $100 running shoe is a very good start for shoe gear. As is a supportive orthotic. These are orthotics that are fairly rigid in the arch. They loft the portion of your midfoot that in most people has collapsed. They loft that. They apply pressure. They bring the ground up into that area, and this is very powerful. That flat foot deformity, that collapse of the arch, that actually is a very strong contributor to bunion deformities. So by essentially fixing that with a supportive orthotic, we can reduce some of the force onto the bunion deformity itself. My go-to orthotic that I recommend, and those of you who've seen me before in my clinic can attest to this, is this Power Step orthotic. I like it because it's inexpensive, it's readily available, and it does a very good job. It's a very rigid orthotic in the arch, and it does a good job of controlling motion. There are plenty others on the market. I just encourage you to, feel the arch of the orthotic. It should be rigid. It should feel hard. A soft, squishy orthotic, although attractive, it just doesn't really do the functional correction of the mechanics that we need. The component here is calf stretching. The big muscle that makes up the calf is this gastrocnemius muscle. In America, we spend a lot of the time sitting at a desk with our knees flexed and our ankles in neutral, and that allows our posterior compartment, really from our hips all the way down to our feet, to contract. I have this, tight calves. Most of my patients have this, and this is another deforming force. A tight calf, a tight Achilles tendon will cause your foot to want to bottom out and will exacerbate a bunion deformity. Now, this is, again, very general, and without a thorough exam, it's hard to apply this to everybody, but a rough estimate of good go-to therapy initially is good calf stretching. When you see me in clinic, I can demonstrate these there. Sometimes we recruit a physical therapist. I really gauge and measure range of motion and work with you to adjust. And now we go on to the accommodative conservative therapy. This is in the form of shoe modification. Some people have cut a hole in the inner part of their shoe to accommodate the bump. A lot of people report some pretty good success with the splint that you see on the screen there. It's usually made of a rubbery silicone. It reduces shear. It provides a barrier between your skin and your sock or your shoe to reduce shear, to pad that bump. And as you can see is the case here, there's a little toe space, inner space padding there to help offload the hallux, that big toe from the second. These are all experimental, essentially. It's something that you're going to need to work with. I can make recommendations as a surgeon, but you kind of need to tailor them to yourself, either custom make them or custom buy them and then custom work with them to make them fit for you in the shoes that you wear. You know, when all else does fail, and if you continue to experience significant pain and you're limited in your activities, despite doing the functional and the accommodative conservative care, there is an indication for surgery, and plenty of people undergo surgical correction of their bunions. Again, not all bunions are created equal. There's over 100 described surgical techniques that are written in the literature, in the scientific literature, on how to correct bunions. And you can see some of those various techniques in front of you on your screen right now. They're not all equal. Each of them addresses a different portion of the bunion. And some of them are more powerful than others based on the severity or the specific complaints of the patients. You know, something kind of unique that I can offer, I do a minimally invasive bunion surgery. This is usually reserved for, you can see it on your center of your screen there. This is usually reserved for people with the more mild and moderate bunion deformities. It can occasionally work for the severe deformity as well, but this is a fairly cutting edge technique. It's only been out for about 20 years and is continuously being refined. This is surgery with correction through very small incisions, usually 5 millimeters, which is really just 1/4 of an inch. And you can see the substantial correction that you can get when the procedure is tailored to the patient, like I do. Another technique that is fairly specific is a total joint replacement of that big toe joint. So for people with more arthritic pain in the big toe, I do a joint replacement there. They can get a lot of relief, and it's a fairly robust procedure that can last quite a long amount of time. Again, I want to emphasize that bunions are not, they're not all created equal. You really do need a clinician to work up both clinically, checking range of motion, checking for muscle contractures, your foot mechanics, and then also radiographically through the use of x-rays. People are, and I hear it all the time, fairly apprehensive about coming to see a surgeon. I can put your mind at ease. We're not going to push surgery on you. And in fact, if I can treat you with some of these tailored conservative therapies, I really am very happy. That's very pleasing. But I hope we can, you know, if we can't, we can address different issues with varying surgical techniques that we'll of course educate you on and really discuss what your post-op recovery is and so on. I think we are running out of time here a little bit. Hopefully we've left some time for some questions. I can see that a few have come in.
All right, yes, thank you, Dr. Kennedy. We do have a few questions. A couple of them kind of fall along the same lines, so I'll combine them. Is bunions, or are bunions hereditary, or is this genetic?
Yeah, so there's definitely a genetic component. So if your mom or dad has a bunion, you are at an increased risk for a bunion, but it doesn't always follow a genetic line. So just because your mom or dad has one does not mean that you're going to get one. We do know that it's a little sex dependent. So females seem to have more bunion complaints than men. They actually develop more deformity than men, possibly because of ligamentous laxity. And we also know that bunions do get worse as we age usually.
Thank you. When we talk about surgical interventions, how long is recovery from bunion surgery typically?
That's a little bit of a loaded question because it depends on the actual technique being done. For 95% of my bunion corrections, people are weight bearing the day of surgery in a boot. So one of those Velcro, I'm sure you've seen people walking around the grocery store with them, boots. That's to protect the repair. We allow you to weight bear. Sometimes we have you augment so that you're walking on the outside of your foot and not putting your weight completely on the inside of your foot. In general, you're in that boot weight bearing for 6 weeks before we progress you into either a shoe, a rigid surgical type shoe, or a athletic shoe. But just because you're in the boot does not mean that you're static and you're completely immobilized. I get you out of the boot at night, you're moving your ankle. Around 3 weeks, we have you start doing range of motion at the big toe. And if we can transition you into a surgical shoe early, you can often do elliptical or bicycle low impact activity. Long term, you're looking maybe 2 to 3 months before you're back to high impact activity like running or sport.
Great, thank you. After surgical intervention, what are the chances of bunions reoccurring?
It's a loaded question. It depends on the mechanical reason for the bunion to occur in the first place, and it depends about a lot on the amount of deformity in the back of your and your rear foot and midfoot. There is absolutely a chance that these can recur. No surgeon will tell you otherwise. The trick with bunions is aligning the axis of that metatarsal from that first diagram so that as those tendons continue to pull, they pull right down the center of the bone instead of deviating off to one side to cause them to recur. Recurrence is definitely a complaint. It's a known complication of bunion surgery. We're dealing with really small bones and very delicate structures that under normal circumstances, they take quite a beating. As we cycle through gait 2,000, 3,000, 4,000 times a day, they take a beating. So yeah, they can recur. If we can get you 10 years with your correction, usually we're doing very good.
And just one more because of time. Are step orthotics available at our local drugstores, or do they have to be specially ordered?
The ones that I was talking about at the beginning, the power steps, they are not available at drugstores, or at least not that I found around here. I do believe the local DME distributor here, Teeters, has them here in Petoskey. We carry them in our clinic. A little known secret, though, you can find them on Amazon for pretty inexpensive. So that's my go-to is Amazon for now.
All right, thank you, Dr. Kennedy, and thank you all for joining us today. Just a reminder, there are 2 links in the chat box. One is a link to submit additional questions or to request an appointment, and the other is a link to register for the remaining 2 virtual orthopedic education sessions. These links will also be sent to all registrants via email. The next session is scheduled for 2 o'clock on Tuesday, May 4th, with the return of Dr. Angus Getz, orthopedic surgeon, who kicked off our series. Dr. Getz will now discuss surgical interventions for the relieving arthritis pain and interventions. The series will then conclude on May 18th with ankle pain solutions presented once again by Dr. Kennedy. All presentations are on Tuesdays at 2 o'clock. We look forward to having you join us again. Thank you and have a good day.